We are moving on to the next session. Next talk is by Dr. Vivek Krishnan on the topic whistleblowers in fetal ultrasound, a topic which we all are very eager to explore on. To say about Doctor, he is the Associate Professor and Head Fetal Medicine and Perinatology, Amrita Institute of Medical Sciences, Kochi. He is also the Adjunct Faculty, KNC Manipal. Welcome, sir.
Thank you for the introduction. And first of all, I must congratulate JK sir and his team. It's no mean task to pull off a conference year after year for 25 years together. So hats off to the KJK team for that. I also bow before the memory of the doyen in whom or after whom this hall has been named, Lalita ma'am. I was brought into this world through her hands, so I bow before her as well. Respected teachers, respected chairpersons, delegates and friends, I've been asked to speak on whistleblowers in obstetric ultrasound. This is a topic that came up after the unprecedented events that happened in Alleppey. We know what happened with the missed anomaly, and that's when this topic was probably suggested. Now, the term whistleblowers has assumed some importance of late thanks to this gentleman on your picture. Some of you might identify him, Prashant Nair, IAS. We warmed the benches of the same classroom for 12 years at Loyola School in Trivandrum, so he's a good friend, and this topic, the name of this topic has been inspired by him. And you know what happened with him, that's beyond the scope of this discussion. Now, whistleblowers in obstetric parlance refers to those key ultrasound findings which are subtle pointers to hidden abnormalities. And if you identify them in time, you might be doing yourselves and the patient a favor in the aftermath of what happened with the Alleppey incident. So the specific learning objectives from this lecture would be to recognize key ultrasound findings across trimesters, which is what we call as whistleblowers in the first place. Familiarize yourselves with critical terms and findings that you need to look for in an ultrasound report, and understand those situations where you really need to seek a specialist input. We'll go trimester wise like Mani did now. So we'll start with the first trimester. The first whistleblower in the first trimester would be a small CRL, a CRL that is less than the gestation age. Now, of course, the first question that you would ask is, why can it not be wrong dates? Of course, the most common possibility is a wrong dates. But before you start to redate the pregnancy because the CRL is small, we need to be aware of the fact that aneuploidies, particularly trisomy 18, trisomy 13, and triploidy, can cause reduction in cell number, and therefore the CRLs can be small in an otherwise unsuspecting mother. Now, trisomy 21 does not have that effect. It does not affect the cell number, nor does it affect the fetal size, but 18, 13, and triploidies have been shown beyond doubt to be a reason for small babies as early as in the first trimester, and you could have disparity of up to 8 days for triploidy and maybe around 3 to 4 days for trisomy 13. So these are conditions that you have to have in mind, particularly if the biochemistry is abnormal. So you've done a first trimester screening test, the biochemistry is all over the place. I mean, if it's either very low, very high, irrespective, when you find abnormal biochemistry with a small CRL in a mother who has regular cycles, please think of the possibility of an aneuploidy before we redate that pregnancy. So that is the first whistleblower, a small CRL in a mother with regular cycles but with abnormal serum markers. The second, of course, all of us know is the increased nuchal translucency. There are a host of conditions that can lead to increased translucency, including aneuploidies, congenital heart diseases, major structural anomalies in the fetus like skeletal dysplasias, infections, or gene disorders like Noonan syndrome. So we have to exclude all of these when you see increased nuchal translucency. But what you would also do well to understand is that increased NT is not always synonymous with dismal outcomes. You could have normal outcomes. For example, the NT is, let's say, in the bracket of 4.5 to 5.4. You're still looking at a 50% chance of a normal outcome. So just because the NT is off does not mean that the baby is going to have a poor outcome. So this is something again we need to bear in mind. But as the value of the NT increases, it spells more and more trouble. So we have a very sequential approach when you find an increased NT, because you're trying to rule out the stuff that I've put there in the right-sided box. First thing is, of course, to do an CVS in the first trimester to rule out aneuploidies. You do also a very thorough early targeted scan at 12, 13 weeks to see if there are major anomalies. You also try and map the blood inflows and outflows to rule out congenital heart disease. You ask for a history of infection or maybe test for infections. And we call them back at 16 weeks if everything is fine. The tests so far are good. We also think of the possibility of something like a gene disorder, one of those rasopathies like Noonan syndrome. So it's a very graded approach. First thing is you rule out a chromosomal abnormality. You call them back at 16 weeks, rule out any further development or something that's coming up new. And then also think of the other possibilities if your chromosome study is normal, and then try and rule out anything else that could be causing the increased NT. A third whistleblower would be an absent nasal bone. Now, does this baby have a nasal bone? Yes? Okay. How about this one? Yes? But both of them did not have a nasal bone. So that's where we need to start looking at pictures of nasal bones. Just because the ultrasound report says there is a nasal bone in the fetus, you should not believe either me or whoever is doing the scan. It would be a good practice to go and audit the images, because we need to understand that in the first trimester, the nasal skin can look quite echogenic because it's banged perpendicular to your ultrasound beam. Therefore, it can look very echogenic and can mimic a nasal bone. So what we have to really look for is to try and zoom up the image. If you have a lens in your clinic, that helps as well. And try and see if you're seeing another line that is bigger and brighter than this line. So this is the nasal bone. If you see in this graphic as well, this is the skin. So that can mimic a nasal bone. What you need to look for is a line that's bigger and brighter than this, below this, which is actually the nasal bone. So both of these pictures, if you look back, this was the skin that's pointed to. The bone that is there, or the bone that has to be there, is not bigger and brighter. So this is just a cartilage that you're seeing. It's still unossified. And in this case, you just see one line. You don't see anything below that. So this is actually the nasal skin and not the nasal bone. So that's again a whistleblower. And we know the importance of absent nasal bone. You can also look at the frontal view of the face to make this very clear. You can see that the two nasal bone dots are missing in what we call as a PMT, or a premaxillary triangle view. This is important because if you say that the nasal bone is present in a baby in which it is really absent, it can really bring down your screening risk, because the likelihood ratio for absent versus present nasal bone is quite different and distinct in the first trimester. To just give you an example, this baby would have been called as low risk because it was 1 in 5,200. But the moment you throw in an absent nasal bone, the risk jumps up by 14 times. So that's how significant identifying a nasal bone is there or not in the first trimester is, because it can completely topsy-turvy the first trimester screening report. The fourth whistleblower in the first trimester is a high uterine artery PI. Rather, a high mean uterine artery PI, because it could be that sometimes one uterine artery shows high distance, the other is normal. When you take the mean, it evens out. So it's always important when you say high uterine artery PI, we always refer to a high mean uterine artery PI in the first trimester. Now, this again is important because if you notice high mean uterine artery PI, you would do a good service to the patient to try and get them screened for preeclampsia, because high uterine artery PI is one of the pointers to the onset of preeclampsia. But if you combine that with the maternal demography and some blood tests, you can pick up at least 75% of all your preterm preeclampsias and maybe 90% of preeclampsias before 34 weeks of gestation. So that is another whistleblower. And we know that if we pick it up, we have treatment available. So if you start them on aspirin, you can bring down the incidence of preterm preeclampsia by around 65%, and very early preterm preeclampsia by up to 90%. So it is again a big service that we're doing to a patient just by noticing the fact that in the report there was uterine artery that was high, and send them across for a preeclampsia screening. The fifth whistleblower, an interesting one in the first trimester, is when you see a report of a vanishing twin. Okay, you find a report of a monochorionic twin with one vanishing twin, as you see in the picture. Now cases get referred to in all sorts of formats. This is one case that came through WhatsApp. So there's a friend of mine who sent an opinion, has sent a picture for an opinion. She says, please give an opinion. It's an MCMA twin, 7 weeks gestation, primary. One baby has a heartbeat. There's another mass, which she thinks is a vanishing twin. So I said this could most likely be a trap sequence because it's an MCDA pregnancy. It looks like an MCMA, but it's mostly an MCDA because you can see a very thin membrane there. And then I asked her to go back and look at the Dopplers, and she calls back, or she messages back saying, yes, you were right, the mass is indeed vascular. The other baby is fine. What should I do now? Shall I refer it 12 to 13 weeks? I said, yes, this is definitely a trap sequence, because if you look at the direction of blood flow, it is vascular, but the flow is towards the fetus in the umbilical artery and not away from it. So this is how you would see it. So she did refer at 12 to 13 weeks. So I find a normal twin. I find a very clear intertwin membrane. And you see an amorphous looking mass which has no shape. It looks like a monster. It has got lots of edema there. And what is critical is to switch on Dopplers. The moment I switch on Dopplers, I find that the direction of blood flow in the umbilical artery of the normal twin is away from the twin, but in the abnormal twin, it is towards. You can see the blue color there, and if I switch a Doppler, it is going downstream. Which means in the artery of that twin, in the umbilical artery of that twin, blood is actually flowing inward. So that is reversed arterial perfusion sequence. Again, very important to understand and pick up this, because otherwise what will happen is you will end up with this sort of a picture. Both twins would have become demised, because if you say it is a vanishing twin, or if the report says a vanishing twin and you believe the report, you will say, now this is just a singleton pregnancy. Why not call her back at 20 weeks? So the anomaly scan, she comes back at 20 weeks, and this is what you see, both twin demises. Okay, this happens because we have not picked up TRAP in the first trimester. And the only way you'll pick up TRAP in the first trimester is to switch on a Dopplers in all cases of so-called vanishing twins. So those were about whistleblowers in the first trimester. We now come to second trimester whistleblowers, and first and most important is early onset FGR. Now, the cause could be intrinsic or extrinsic or both, but irrespective, when you see early onset severe FGR, the outcomes are usually guarded. Not always poor, but mostly guarded outcomes. The second is, for example, if you find FGR at 20 weeks, 22 weeks, how much can you push them to a viability or to a salvageability? So it's usually associated with poor outcomes. Similarly, when you find an increased nuchal fold thickness, now this is the second trimester equivalent of increased NT, the implications are pretty similar. But we have to understand that the normal range for nuchal fold thickness is different from the normal range for NT. So any NT above 3.5 we would consider as significant, but that does not apply to nuchal fold thickness, because the normal range for nuchal fold thickness is above 6 or below 6. So if you find a nuchal fold thickness of 4.3, do not equate it to an NT of 4.3. This is again something that we see quite often. There is a report of a nuchal fold thickness of 4.3, and we get a referral for a second opinion saying that the nuchal fold is high. No, the normal nuchal fold thickness is up to 6 millimeters, so this should not be confused with increased nuchal translucency. But if you had a baby who had increased nuchal translucency, we did all the tests that I said at the beginning, and she comes back at 20 weeks and there's still nuchal edema, that's when you would think of conditions like Noonan syndrome or the other rhasopathies, where you could have effusions into multiple body compartments. The third whistleblower would be soft markers of Down syndrome. Now, we know the four main markers: absent nasal bone, increased nuchal thickness, borderline ventricular fluids or ventricular megaly, and what we call is an aberrant right subclavian artery. So these are your four major markers. You could also have minor markers like echogenic bowel, short femur, short humerus, and echogenic intracardiac focus, pelvic chases, etc., etc. But what we need to understand is, if it is a patient who's had a good first trimester screening test, maybe one marker might not significantly increase the risk, because remember, the combined test in the first trimester has a negative predictive value of 99%, which means if the combined test shows low risk, the presence of markers may not significantly alter her risk. But if you find more than one marker, or if you find other structural abnormalities, it may be wise to do invasive testing in them. Fourth whistleblower, of course, would be structural anomalies. Now, this is what we need to understand. The structural anomaly could be isolated or it could be associated. When we say associated, it could mean a structural association, meaning there's something else other than the major finding, or it could be a genetic association, which could be a chromosomal or a single gene disorder. So when you say chromosomal abnormalities, we refer to the aneuploidies, the common trisomies and triploidy, or it could be a submicroscopic deletion or a duplication which you cannot pick up with a karyotype, which we call as copy number variations, or it could be an abnormality at the gene level. For example, the syndromes, the name syndromes like Noonan's, Charge, etc., etc. So all of these would present as structural anomalies. So a structural anomaly in a second trimester, I'm sure all of you would agree, is definitely a whistleblower. You need to test further to find out whether it's isolated or associated, because some of these isolated structural anomalies could still have normal outcomes. And there are different tests for each of these, which again I think is best decided by a fetal medicine specialist. So this is one indication where you definitely you would want to refer. The fifth whistleblower in the second trimester would be a vasa previa. Now, the second trimester is a good time to really look for this, because the baby is not too big, you have plenty of liquor, and the cervix is often very clear. And you can see this, that there is this vessel that looks to be stuck to the internal laws, or just crossing or traversing the internal laws, and there is flow inside. Now you can tap your probe a couple of times to see that this is just a free floating loop of cord which will then move away. We call it a sliding sign. But if it doesn't move, it is stuck to the membranes there, and that is your classical clue to picking up a vasa previa in the second trimester. And if you switch on color, you can see that there is blood flow in the cord loop as well. So this is not a free loop of cord, because you tap it, it doesn't move, it just stays put. That tells you that this is a vasa previa. And the conditions where we definitely suspect a vasa previa is when you have a velamentous cord insertion, where you can see the placenta is here, but the cord is inserted here and it runs through the membranes in front of the cervix. Or probably when you have a succenturiate lobe of placenta, connecting the two lobes, you could have vessels going like this, and this could overlie the cervix. So any case where you find a report of a succenturiate placenta or a velamentous cord insertion, make sure that the vasa previa part of it is ruled out. So those were about whistleblowers in the second trimester. In the third trimester, the first thing that all of us would do well to understand is that when you have unexplained polyhydramnios, it's always something that you need to be worried about. Specifically if the Leica is exceedingly high, because in GDM related polyhydramnios, the Leica volume never usually exceeds 25 or 30 centimeters. But if you find 35, you find 40, 45, 50 centimeters of AFI, there has to be an underlying pathology. Now, when you find an AFI that's above 30, it is either because the baby is not swallowing well, or it is swallowing, or it's swallowing well, but it's putting out putting out lots and lots of urine. So these are the only two causes, because we know that the Leica is nothing but the baby's urine. So if there's plenty of urine, it means either the baby is putting out a lot of urine, or that urine is not getting cleared by the baby's swallowing. So what are the possibilities you could look at? Reduced swallowing could be because of esophageal atresia. Myopathy is the baby's muscles are not moving. Remember, we need 50 muscles to swallow down a bolus of water or food. So if your muscles are not working due to some genetic abnormalities, there could be unexplained poly. Or if you have a cleft palate, the swallowing is reduced because half of what you drink or what the baby drinks is going to come out through the cleft in the palate. So these are conditions where there could be reduced swallowing and increased Leica. Increased urination is far less common, but you could see it in severe fetal anemia and also in some genetic conditions like Bartter syndrome. So when you find unexplained poly that's beyond the realm of diabetic polyhydramnios, then again it's a whistleblower and our antennas need to go up. Even more so if you have growth restriction associated with the polyhydramnios. Now this is a very unusual paradoxical combination, because when you find growth restriction you expect less Leica. But you see growth restriction and more Leica, there is something that's happening wrong. This is exactly what happened in the LFP case as well. So the baby had growth restriction, but it had polyhydramnios. The third whistleblower would be a baby that is looking normal in terms of size, but the Dopplers are probably still okay, but you find that the baby is dropping centiles. It was at the 80th centile some time back. Now it's at, say, 20th centile. So there's been a 60 centile drop, but 20th centile is not still small, because by definition, SGA is only when it is less than the 10th centile. So you have a baby that was at the 80th centile, now dropped to 20th centile. Technically, it's still appropriately grown for gestational age, but if you plot this on the growth chart and you extrapolate this line, you will realize that at some point in time, this is going to come below the 10th centile. So this is what we call as AGA-FGR. This is again a very important cohort. The numbers may be small, but most of the term stillbirths happen to such babies because they go undetected. You think the baby is growing normally. Dopplers may not be very bad because the umbilical artery Dopplers are going to be normal. The MCA might also be normal. The ductus is anyways normal. So we'll think this is just a small baby, just a normally growing baby, and suddenly you end up with an intrauterine demise. So that is typically because AGA-FGR was not probably picked up. And here I think it would, if you find a baby that's dropping centiles, even if it is above the 10th centile, but there has been a 50 centile drop or a 40 centile drop, make sure that we look at one particular value, which is the cerebroplacental ratio, because the individual Dopplers, the umbilical artery and the MCA might individually be normal, but a CPR starts to show an abnormality even before these become individually abnormal. So a baby that is dropping centiles with an abnormal CPR is again another whistleblower. The fourth one in the third trimester would be a patchy or an unhealthy placenta. The baby's growth might be fine, Dopplers might be normal, the Leica is good, but you look at the placenta, it looks very shady. I mean, as in you have multiple hypoechoic spaces of what we call as lacunae. you do not find a very clear demarcation of the retroplacental space. It looks as if the placenta is stuck to the uterus at this point. You find a very irregular bladder serosa interface, and you find abnormal vascularity at that interface. These are signs of a placenta, adherent placenta, and this may not be missed if you really don't look for these, especially if there's a mother with a previous cesarean and an anterior placenta. So very, very strong whistleblower. These changes in the placenta should alert suspicion. Lastly, if you have sudden reduction in fetal movements, a mother has been experiencing good fetal movements till 32 weeks, 33 weeks, and suddenly at 34 weeks, she finds that the movement is off. So sudden reduction in fetal movements, always think of fetal anemia. Now, she may not have any of the traditional risk factors. She might be rhesus positive. It might not be a twin pregnancy, no history of parvovirus infection. But one silent killer there is a fetal-maternal hemorrhage, which will go completely undetected unless you do a Kleha-Bethke test. So if a mother suddenly complains of reduced fetal movements, there's none of the other risk factors. Always think of the possibility of a silent fetal-maternal hemorrhage, which you will pick up if you do an MCA Doppler. The MCA PSV is going to be very high. And then if you do a Kleha-Bethke test, your diagnosis is very, very straightforward. So those were the 15 whistleblowers that I wanted to draw the attention of all of you to. Lastly, I'll sum up with this. If in a report, you're looking at a report of an ultrasound and you find some, what I call as whistleblower jargon. For example, somebody says not well visualized, could not be imaged satisfactorily, could not be assessed properly, suboptimally visualized, suspicious of, needs to be reassessed. These are whistleblower jargon, which means they have suspected something but not really sure about it. Please do get a second opinion in such cases. Thank you for a very patient listening.